Yes, sir, you are audible.
Yeah, a question for all of you are seated there, fellow physiotherapists. Yes, is it a condition or a symptom? First question, open to all. Is it a condition or a symptom?
It's a condition.
Condition. Okay, that's nice to know. Good question. And first of all, understand that lymphedema is a condition in itself. Okay, what are the types of lymphedema? What are the types of lymphedema? Anybody?
So two types, primary and secondary lymphedema.
Primary and secondary lymphedema. Good. And any lymphedema that is related or post-cancer treatment would be considered as primary or secondary?
Secondary.
Secondary. Excellent. Any other example apart from Dr. Vandana Patel? Anybody else would like to contribute? Thank you, madam, for your answers. Anybody else about any other kind of secondary lymphedema? Secondary lymphedema. Let that be an interactive session. Louder, please. So anyway, let me tell you, lymphedema should be considered as a condition, first of all, for our understanding. Second, there are two types of lymphedema, primary and secondary. Primary lymphedema, basically by birth or sometimes at the time, which shows at the time of puberty or little later. Lymphedema precox, lymphedema tarda are all examples of primary lymphedema. And secondary lymphedema basically refers to anything that happens post-cancer, because if there a cause can be attributed to that. For example, you have got after radical mastectomy, okay, post-breast cancer, you've got lymphedema. In many other conditions also, you've got lymphedema as a condition, secondary to a cause, so it is secondary lymphedema. Apart from that, you have filariasis, which is also kind of lymphedema, okay, caused by the filial worm, it's secondary lymphedema. So lymphedema is quite, it is something that needs to be addressed. It is a condition, and we are going to see as to how to go about with the assessment primarily. So shall we go ahead with things? So the next one is the assessment of lymphedema. Now, have you heard of this Emma? Is the screen visible?
Yes, sir,
Yeah. So we need to understand that for any kind of symptom, this is the general approach, we need to have an evaluation. Diagnosis of each symptom before treatments, correct? Evaluation, explanation to the patient before treatment. Third, management, individualized treatment. Fourth is monitoring, continuing review of the impact of treatment, and attention to detail. No unwarranted assumptions. You need to know it objectively as to what is happening. So this is a very good acronym. I believe it was developed by Robert Twycross, who is one of the leading palliative care physicians. So you can make a note of this. Evaluation, any symptom in palliative care, as physios, as clinicians, as we deal with the symptoms, this is very important. Evaluation, explanation.
Sir, can I interfere for 1 minute, sir?
Yeah.
Sir, actually your voice is little bit echoing, sir.
But now is it clear?
Yeah, a little bit better, sir.
Yeah. Is it better now?
Now your voice is little bit slow, sir.
Little slow. Okay. I try to raise my voice and try to, make it better.
Okay, thank you, sir.
Yeah. So evaluation, is that clear to everyone?
Yes, sir.
Yeah. Next is explanation, management, monitoring, and attention to detail. I'll not be spending much time here, but would just like to bring to your attention these aspects. Let's go a little forward. Okay, so as I said, evaluation is important. So we at Karnashraya, when we have got a lymphedema patient, we follow this kind of an assessment wherein we first take the important details of the patient, namely the name, age, patient number, the address, phone number, diagnosis, and then we go to the chief complaint, because lymphedema seldom presents itself as just edema. There are other things also involved with it. So you need to see there can be pain, there can be swelling, infection, heaviness of limb. So all these needs to be checked at the very beginning, the chief complaints of the patient. history of the presenting illness. Followed by that, we have a body chart. A body chart is important for us to know which area is edematous, whether it's the upper limb, whether it's the central lymphedema or peripheral lymphedema. Okay, we need to know whether it's upper limb involved or lower limb involved, and if it is upper limb and lower limb, which part of the upper limb, which side of the upper limb. You know, that is very important for us to have that. Next, we need to know the onset of any of the symptoms. What is the type of pain, the measurement of pain, the nature. I mean, many of these things you are aware of, so I'm not spending much time. Then girth measurement, very important aspect of lymphedema assessment is girth measurement. Am I audible? Is the screen visible?
Yes, sir. Yes, sir.
Yeah. So we've got the girth measurement in centimeters. Which unit you are using is very important. So concentrate on the units. So you've got measurement around the axilla. When it comes to the upper limb, 5 centimeters above. You know, elbow. The joints are very important. One aspect of lymphedema measurement, we should remember that lymphedema loves joints. So it is very important to have joints measurement very specifically during the lymphedema assessment. Then going further, range of motion. There's some of the methods that people employ. Okay. And stages of lymphedema. You've got a subclinical stage. Anybody aware of ISL grading? It's the International Society of Lymphology. Do you use? So for your information, the International Society of Lymphology has come up with a grading system, which is very important for us to know when it comes to lymphedema, which grade it is. Though there are more symptoms being developed as part of research and development, so that we have more robust systems to measure the extent of lymphedema. But this is one of the standard measurements that we use. Stage 0 or 1A is known as subclinical state, where swelling is not evident. Despite impaired lymph transport, this stage may exist for months or years before edema becomes evident. Stage 1, this presents early onset of the condition, where there is accumulation of tissue fluid that subsides with limb elevation. The edema may be pitting at this stage. Limb elevation alone rarely reduces swelling, and pitting is manifest. Stage 2. Late stage 2, that may be or may not be pitting as tissue fibrosis is more evident. And the last one, the hard edema, which will not correspond to much of the treatment. Stage 3, already fibrotic, pitting is absent. Skin changes such as thickening, hyperpigmentation, skin folds, fat deposits, warty growths are common. But we can definitely have our interventions from 0 to 2, late stage 2. Okay, so going forward. Okay, now we'll be moving on. Are things clear till now? Any doubts till now? Very basic understanding that I've given. Any doubts till now? Am I audible?
Yes, sir. You are audible, sir.
Yeah. So we'll go to the next one. Just a second. We'll have to see one more presentation, and then we will have the discussion. Sudarshan sir. Yeah. Okay, coming. What is lymphedema?
It is the collection of protein-rich fluid into the interstitial spaces.
Exactly. Collection of protein-rich fluid in the different interstitial space, or you can say just below the skin. Most of it is just under the skin. Subcutaneous, right? Most of it is subcutaneous. Interventions are very, very important. Now, lymphedema being a condition that many of our cancer patients suffer from. we need to put our strong efforts to ensure that there is a psychological aspect, the physical aspect, the spiritual aspect of lymphedema is taken care of. Now, what are these aspects that I'm talking about? You know about the concept of total pain. Lymphedema is not just a swollen upper limb or a swollen lower limb. Lymphedema is more than that. Imagine you as a physiotherapist or you come across a patient who has got lymphedema. What are the considerations? Suppose there is a family function. The patient is otherwise active. The ECOG score, okay, is good. Patient's performance status is good, or he or she wants to go for a function, and he or she has got lymphedema. And then what would be the psychological frame of that person, okay, in going for a function? If he or she goes for a function, okay, the first thought that would come is, how many questions would arise? How many people would ask the person, why did you get edema? Though the people may know about she has cancer or something, but still they would ask a question, why is your hand swollen? What has gone wrong? Even if she covers it up with a dupatta or a sari, even the question would be very pertinent. So she would rather not go for the function. So there are psychological aspects, there are social aspects, there are body image issues, there are spiritual issues that the person may go through. So as a physiotherapist, though we look at the physical aspect, being in the palliative care arena, you and I should know that we should be concentrating on these aspects as well. Holistic approach to the individual. Okay, this is just by the way, I just shared that with you, but I'd like to go to the details. Okay, coming to the lymphatic system. Okay, what are the components of the lymphatic system? That we'll be looking at the slide and we'll be learning that. The components of the lymphatic system, because that is very important for us to understand lymphedema, specifically to intervene in lymphedema cases. It's very important for us to understand the anatomy of the lymphatic system. So I'll be touching upon that very shortly. Just waiting for the facility manager to come to get the PowerPoint in place, because there are some issues, technical issues with the screen. So please bear with me. Within a few seconds, we will be back to with the screen so that we can, look at the PowerPoint and you'll get a better idea.
Sorry for that delay. Actually, till he comes back, we can just go through the things here. We have seen, like we have been discussing about the introduction part, like what is lymphedema and its says and all. And if you have any doubts or any queries, you can just speak up, or you can just put it on chat box so that we can discuss that questions and everything later stages.
A very good evening to everyone. This is Vanna Patel, working as an assistant professor in Government Physiotherapy College, Raipur, Chhattisgarh, and also working as the rehabilitation in charge of Regional Cancer Center, Chhattisgarh. So I'll be presenting a topic on lymphedema. This is my case presentation. My patient's name is Mrs. Urmila, who is 50 years of age, and by occupation, she's a construction worker. Diagnosis is right CA breast with lung and brain metastasis. Next slide. So her presenting complaint was there was pain and heaviness in the right arm with swelling in the right arm since 3 months. Inability to do the overhead activities, and the patient was also complaining of breathlessness. Next. So the history of presenting illnesses. Patient noted the ulcerative lump on the right breast 1.5 years back, and she took some medications from the general practitioner of the village, but that doesn't help her, and so she approached the gynecologist at the Raipur city. Patient underwent toilet mastectomy in January 2021, and she was advised ER/PR HER2, which came out negative. She was then referred to the Regional Cancer Center, Raipur, where 4 into 3 centimeter mobile axillary lymph node was ruled out on palpation. Chest CT revealed the presence of conglomerated metastatic lymph nodal mass in the right axillary region. On 14 July 2021, axillary lymph node dissection was done, and the patient then received 8 cycles of chemotherapy. in which 4 cycles of epirubicin, cyclophosphamide, and 4 cycles of taxanes, that is the paclitaxel, was given. She was then discharged. On 25th December, patient then came with the complaint of breathlessness. CT chest and abdomen was done that showed multiple lung metastases, and CT abdomen was normal, for which palliative chemotherapy tablet capecitabine was started. On 31st of December 2021, she complained of headache and vomiting. CT simulation was done that revealed multiple brain metastases. Whole brain RT was done with 30 grays in 10 fractions that got completed on 20th January 2022, and the patient is still in the hospital. Next. So on examination, on inspection, there was swelling in the right upper limb that extended up to the fingers. There was an incisional scar on the right chest wall and axilla, and visible knot was there in the axilla that got pop out during overhead activity, particularly the abduction movement. On palpation, it was a pitting edema, and stemmer sign was positive, and it was a stage 2 lymphedema. Shoulder range of motion, the flexion was 0 to 100 degree, abduction also 0 to 100 degree. External rotation, internal rotation, and shoulder extension was within normal limits. Pain on the VAS score was 5 out of 10, and the patient was complaining of pain during the end range of shoulder movement. The MMT was done. The shoulder flexor extensors, abductor, adductors, and external internal rotators were graded grade 3+, and lower limb muscles were graded grade 4. Girth measurement was done. The limb circumference was taken at the level of metacarpal head, then at the level of wrist, 5 centimeter below elbow, at the level of elbow, 5 centimeter above elbow, and at the level of axilla. And it was done with the help of inch tape. Next slide. Treatment investigations were done, like the chest CT and abdomen CT was done that revealed the presence of subcentimetric sized fissure based soft tissue density nodule along the right oblique fissure. CT simulation showed multiple brain metastases, and color Doppler ultrasound was done to exclude the DVT and other venous abnormalities. It revealed the presence of subcutaneous swelling, so it actually confirmed a provisional diagnosis of lymphedema. Medical treatment, 8 cycle of chemotherapy was given, and whole brain RT was done, 30 days in 10 fractions. Physiotherapy treatment included relaxed diaphragmatic breathing exercise in anti-dyspneic positions, pectoral and shoulder capsular stretch, and diaphragmatic breathing exercise was synchronized with the movement of arm and chest. So it was chest mobility exercise basically that was synchronized with the breathing. And complete decongestive therapy, including the intermittent pneumatic compression, compression stockings, remedial exercise, and skin care. Ultrasound and DTFM was done over the axillary body. Next slide. Psychosocial aspects were, there was reduced self-esteem with the negative body image. There was lack of motivation. The patient has stopped going out, meeting the relatives and all. So there was social isolation also. Patient had 2 children, so she was actually worried for them. And patient was not able to do her work. So this was a reason for the financial burden. As I have told that patient is a construction worker, so they have to carry the bricks and sand on their head in the construction site. So this was a bit difficult for her, and she was not able to carry out her work, and this caused the financial burden on the family as well as the patient. Next. Medications were tablet capecitabine, and she's still on this chemo. Supplemental oxygen via face mask, dually nebulization 8 hourly, injection berifilin 110 milligram intravenously 8 hourly, injection Pentoc 40 milligram intravenously 24 hourly. Tablet, it's multivitamin B complex. Please read it as MVBC. So multivitamin was given 1 OD, and tablet iron and folic acid 1 OD, injection dexamethasone 8 milligram intravenously 8 hourly with tirapeculosis 30 milliliters during night. Next. So the main concern were like the physical concern was the patient having pain and swelling in the arm with difficulty in doing overhead activities and breathlessness. Psychological concerns included there was a negative body image, low self-esteem and motivation. Socio-economic status was poor for the patient and family. And the spiritual concern was like, I am poor and not able to earn my bread, and now the disease has happened to me, poverty has surrounded me from all sides. These were the words which the patient used to tell during the treatment. Next. So the summary is 50 years old female patient with right CA breast with lung and brain metastasis, having physical, psychosocial and spiritual issues. Next, please. So now the question is, how can we ease the patient's symptom? And since the patient belongs to the BPL class, then what can be done to reduce the financial burden of the family? As the patient is on chemotherapy and radiation, so like how can we help the patient in getting the treatment? Thank you.
Thank you, Dr. Vandana, for the wonderful presentation. And as we have finished our presentation, now we can go to the discussion points. Now it's time for the participants to open up and speak about the remedy. So how we can speak about how we can tackle these problems of this patient. I request all our participants to open up and speak. As we don't have any inputs now, I think we can move on to continue our presentation. Over to you, Mathew, sir.
Yeah, thank you.
Thank you.
Yeah, case is a wonderful case. The inputs are very important. The way the assessment was done is very important. Was holistic. But I have one question. Was the cognitive assessment carried out for this individual? Was a mini cog or any kind of a cognitive assessment carried out for this individual? Is it important? Mostly we we deal with patients with lymphedema who have CA breast as the major diagnosis. My question is, this case CA breast with brain metastasized to the brain. In that case, it would be wonderful if we have a cognitive assessment of the patient. That will help us to understand where the person, how much the person understands about the condition. So cognitive assessment, a mini mental state examination, or a mini COG would be highly efficient in enabling us to understand where the person stands. Second aspect, if you look at this individual, loss of interest in routine things, in things that she used to do, which is a clear-cut indicator that she has some of the other kind of depression. So to find out how much she has or the severity of depression, there is a scale called Patient Health Questionnaire, PHQ-9, because we're looking at a holistic approach, right? So as physios also, you can administer this questionnaire, PHQ-9, Patient Health Questionnaire 9, which gives an understanding of our mental state and the severity of depression. Now coming to the next part of it, about the lymphedema management per se. I'm not going to the slides, but I'd like to directly go to the management part given the time constraint. I'd like to go to the management. What are the pillars of lymphedema management? Lymphedema management is important. We understand lymphedema is a condition. What are the pillars of lymphedema management? And we'll come back to the next question about this lady that Madam had raised regarding a financial burden on the family. How to deal with that? There, I think the counselors or the social workers play a major role. Here, we need to connect with people or agencies which help out such individuals to ease out the financial burden, to give some support to the children, who are a major concern for the mother. So that can be dealt with. By the time we think of that, let us come back to the lymphedema aspect. What are the pillars of lymphedema management? I need an interactive session, so let us utilize the time that we have effectively. What are the pillars of lymphedema management? Anybody in the group? You're free to say, even if you go wrong, that's fine. Even if you know more about the subject, please come in, pitch in, and contribute. Yes.
Right.
What are the pillars of lymphedema management? Please speaking.
Rest, eyes, compression, elevation.
Is it
Anybody has
decongestive exercises?
Complete decongestive therapy. Skin care.
Okay, complete decongestive therapy. Can you explain that? I'm happy about your response. Can you complete decongestive therapy? What are the components?
Bandaging, decongestive exercises.
Can you come in order? Right.
So,
Yes.
first is the pneumatic compression and the lymphatic drainage. It could be manual. The drainage could be achieved by the manual lymphatic drainage, as well as the pneumatic compression also helps the same. Then multi-layered limb bandaging and remedial exercises and skin care.
Skincare. Thank you for all your inputs. It was good. It was active participation. Now we'll go to the points. Okay, let us start now. The first management when it comes to complete decongestive therapy should start with skin care. Getting that? Skin is known as the acid mantle of the body. It is the largest organ of the body. And if adequate skin care is not given, you're actually opening up the body to infection. Correct? All of you have seen lymphedema patients, correct? What happens to the skin? The skin is stretched out, correct? So it is very important for us to ensure that the stretched out skin is moisturized. And what do you use for as a moisturizer? You use oils or emollients which have low pH, correct? Coconut oil is one of them. Low pH skincare things should be used for the skincare is a very primary thing. One of the pillars of lymphedema management. How many of you are practicing skincare or give importance to skincare? And how many of you use emollients and moisturizers on a regular basis for the patient, or at least emphasize on that in a hospital or a hospice setting or home care? Have you been emphasizing that? Have you been telling the nurses of the importance? Have you been educating the nurses or the caretakers at home? I would suggest
Yes.
People who care for the patients, we should be educating our fellow nurses or fellow physiotherapists or people who take care of our patients at home about skin care, which is very important. What happens if skin care is compromised? Skin gets dry and skin gets cut. What can happen? I told you it's interactive. The earlier your answer, the earlier we can finish and effectively utilize the time. What happens if skin care is not provided? What can happen? What are the adverse effects that can happen?
Reduced healing.
Yeah.
Excessive dryness can cause scaling.
Excessive dryness. Okay, it's dry. Dryness doesn't bother the patient. But what can happen further?
Infection, cellulitis.
Cellulitis, infection, correct? That's the problem.
Yeah.
You delay the healing, correct? And you have a double challenge at your dealing with the patient. So infections are an issue. Cellulitis is a concern, correct? So skin care is very, very important. What is the next thing that you do? You give proper skin care. What is the gap between applying skin care and you doing the bandaging? You do apply moisturizer and everything immediately do the bandage? Or do you have a gap? Can you immediately start the bandaging or do you have a gap?
There should be gap.
There should be a gap?
Yes, sir.
Or there shouldn't be a gap?
There should be a gap.
Why there should be a gap?
Because that will cause skin irritation by like the sweating will get increased and the patient will not be able to cope up with the bandaging, and so she's not cooperate with the treatment also.
Thank you, madam. Keep this question with you. I'll be asking this question after my explanation after a short while. You should answer this question, okay? I'll be telling the reason. Okay, you should at least give a gap for sure. Why the gap is given, I'll be explaining. After you do the skincare, what is the next step? Skincare is taken care of. What is the next pillar of management? After the skincare, the next pillar of management is manual lymphatic drainage. Correct? Initially, decongestive therapy or complete decongestive therapy can be divided into two phases: the intensive phase and the maintenance phase. Correct? Intensive phase and the maintenance phase. In the intensive phase, you do skincare, you do manual lymphatic drainage, then you do the remedial exercises. Okay, so you've got skincare, manual lymphatic drainage, you have got compression bandaging, and then the remedial exercises. Okay, and then importantly, the fifth pillar of management is patient education. Educating and empowering the patient caregiver, whoever it is. We should, or the significant others, correct? We should be able to empower them and tell them what we are doing, why we are doing. We will not allow any kind of bangles or tight fitting clothes on the affected side. We will not be taking blood pressure measurements on the affected side. We will not be using IV lines on the affected side. Patient tags should not be used on the affected side because again, it will all affect skin care. It will open up the skin to infections and that can end up the patient in trouble and management will be delayed. Cellulitis can set in. Correct? So these are the things. Skincare is important. Second is manual lymphatic drainage. Now, what is manual lymphatic drainage? How many of you practice manual lymphatic drainage? You're practicing. Is it like massage or is it different?
It is a superficial.
Correct. Correct. So suppose if you have got this case that we were discussing, madam, which side was affected? Right CA breast, right? Right upper limb edema. Am I right? The case that we were discussing? Correct. So how do you start manual lymphatic drainage? What do you do first? You have explained everything to the patient, skincare has been given. Now you're going to start manual lymphatic drainage. Which side will you start first?
Unaffected side.
Unaffected.
Side. Okay. Before the unaffected side, what will you do? So that means you mean to say left the upper limb you will try. You will start with. Before that, will you do something?
Diaphragmatic breathing.
Yes, madam.
Diaphragmatic breathing, then followed by the
Diaphragmatic breathing followed by
the stimulation of the neck lymph nodes, then the supraclavicular lymph nodes, then the lymph nodes of the unaffected side.
now this is very some disturbance from somewhere. Yeah. So if you are using manual lymphatic drainage or CDT, 45 minutes should be given in draining the central lymph nodes and the unaffected side. 25 minutes you dedicate to the affected side. Am I clear in this? Is everybody with me? Am I audible?
Yes, sir.
Yeah, 45 minutes of manual lymphatic drainage should be dedicated to the first one, as I said, the diaphragmatic breathing, as madam said, the cervical lymph nodes, correct? Supraclavicular lymph nodes, jugular lymph nodes, the parasternal lymph nodes, and then you go to the unaffected side. In this case that we're discussing, about one case in Chhattisgarh, we start with the left side. After you finish the central and the superficial lymph nodes and the parasternal and the axillary on the unaffected side, then you start with the unaffected side, then go to the affected side. And anybody here can demonstrate on their forearm how is a manual lymph drainage done? Can anybody demonstrate quickly so that it will actually help us to save time and go ahead with things?
So like in this pattern we used to.
What madam is showing is the exact pattern of how you do it, correct? But then you start with the proximal or the distal side?
From the proximal.
Proximal side first. Drain the proximal first and then the distal.
And then yes.
And there is a pattern. When you start like this, am I visible to everybody? I'm going to show you the pattern after the diaphragmatic breathing, cervical lymph node, jugular and suprasternal, supraclavicular lymph nodes, and parasternal lymph node drainage. I'm going to show you the pattern of doing it on the unaffected side. So, am I visible to everybody? Shall I go ahead to show? Am I visible?
So we cannot see your hands, sir. So can you?
Now?
Yes, yes.
So
yes.
Skin to skin. It's always skin to skin. You use this hand, you start with the shoulder. Lymphedema loves joints. So you will find that your patients will always have more swelling at the shoulder, elbow, wrist. Sometimes the wrist and the other parts will appear as a different entity. Correct? So you start with the shoulder first. You don't do it on the cloth, you do it without the clothes. Clothes off, and you do it very gently as Madam had demonstrated. You start here. Then you start this way. You go to the arm, the back side of the arm, and then you go back. So it is incremental. You do it and you go back again. You clear it up. Again, the arm. You do it this way. Got it? You do it this way. Again, you go back. Same way the elbow. And I'm showing it very fast, but you will definitely pick it up this way. The joint specifically. And then again, go back. Again this. Again back. So every time you go 2 steps forward, 1 step back. Same thing here. You start with this part of the forearm. And then you go back again. And then you go back. Correct? And then you go this way. Now this is very fast. This is not the way it should be done. It's actually damn slow. You go this way, then you go with all the fingers and then the palm. Then you go back. And then you go back to the other side. Correct? Now, after you do this, you start with the affected hand. You need to cover and finish the unaffected side and then start with the affected side. Same pattern. Am I clear? Now the problem with moisturizer or anything that is applied just before your intervention is you will not get skin traction if moisturizer is applied immediately before your intervention. So moisturizer must be applied. What is the gap between the application of the moisturizer, emollient or any cream whatsoever below with low pH? What is the time gap? I do not know. I'm not aware. But I'm very sure that it should not, at least 1 or 2 hours is what I use clinically here. So they apply whatever is required 1 or 2 hours before I start my intervention, and then I start my intervention. Then that time skin will be sufficiently moisturized. At the same time, I have sufficient traction to move the lymphatics in the right way. Now my problem with pneumatic compression devices is this. Pneumatic compression devices always use the pressure from distal to proximal, and they just press like this. Do they follow this pattern or channel of lymphatic drainage? They do not. So I have personally a problem with the use of pneumatic compression. In the decongestive therapy or complete decongestive therapy that we're discussing and talking about, there are 2 phases, the intensive phase and the maintenance phase. In the intensive phase, as I rightly said in the beginning, you start with skincare, followed by manual lymphatic drainage, followed by compression. Now, what is to be used in compression? One big mistake that we usually make is in our setups, even in our setup here also for a long while, we have been using crepe bandages. Crepe bandages can cause chronic wet effects. That's why all of us should switch to short stretch bandages. Correct? Are you getting my point? Always think of short stretch bandages. These are available in the market today and more than before, because initially we were struggling to get that product, but nowadays it's available. So you start with skincare, manual lymphatic drainage, followed by the third point, you start with multi-layer dressing. Multi-layer dressing, you should start with a stockinette. A stockinette is a free-flowing garment that can be put over the lip before you do the bandaging. Then you start with elastomer. Elastomer is not roller bandage. Roller bandages are very dry and kind of little sharp, which will affect the skin. Elastomers are available in the market, which are soft. You do the finger bandaging. Followed by the finger bandaging, you start with the foam roll. Okay, multi-level bandage should have a foam roll. You don't use gauze pad or other things for that. You should be sticking to, maybe in our resource pad settings, we may use cotton pads and all, but we should put an effort to switch to foam pads. Are not that costly, they are available in the markets. It is cost effective. Why it is important to put foam rolls? It will give a proper counter to the skin. Your lymphedema patients are not having a perfect contour of the body. When I say contour, the shape. So if you don't put the proper foam padding, you are not going to do justice or giving proper compression to the patient. So foam padding is essential. Followed by foam padding, you go with the short stretch bandage. Correct? With 50% stretch, 50% overlap from from top to bottom, you apply that. 23 hours you need to keep it on, and just not for the last 23 hours minimum in the intensive phase. You need to put on the entire multi-layer dressing. I think I've done justice to what was assigned to me. Over to all of you for further questions in this regard. Okay, then we'll discuss further. There are a few more things I have to say, but then over to you. Is this clear till now, or have I been very fast? Any doubts, audience, fellow physios, or others from the group?
No, sir.
Any questions? How many of you have been using short stretch bandage or foam pads regularly?
Sir, I do use
Sir,
short stretch bandages, sir.
Which one?
Rub bandage.
No, please switch to short stretch bandage. Prep bandages can cause compromise, a neurovascular compromise with respect to lymphedema patients. Short stretch bandages on the top of foam pads are internationally considered, or research-wise also, they are considered the best. Okay, please.
Okay, sir. Okay, sir.
So I have been using the short stretch bandaging, like the complete decongestive therapy.
Good. With foam pads as well?
Pardon?
Foam pads? Foam.
Yes, sir.
Very
Foam
good.
pad also. Yes, sir.
And how is the result? How do you use the elastomer for the fingers? What do you use for the fingers?
So in the kit only it's available. So
Lymphedema kit is available. Good.
yes, sir. Lymphedema kit.
And I appreciate that because many of the settings, even last setup also, we were not getting the kit for a long while. Now kits are available and they can be used, and you've got 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter.
12 centimeter.
Short stretch bandages are available. Right? Good. Anything else?
Sir, but sometimes these kits are not cost effective. So, and if patient is not affordable, then is there any alternative?
Yeah, let me tell you. These kits, we may think that the kit is something very, very costly. Let me tell you, the kit costs 3,500 if it's bought as a kit. Okay, with GST, it's 3,500 with 3, short stretch bandages, 1 big roll of foam pad, 1 stockinette, and a 3M micropore. Correct. So these are the things that it consists of. Right? Yeah, exactly. And elastomer, 2 elastomers for the fingers. So this is what a kit consists of. Now, if you don't want the kit, don't go with the kit. You go with the individual items as per the patient's requirement. Again, the cost will come down. Correct. Instead of us using, cheap things which are available, and then that may cause damage to the patient. Isn't it wise for us to, put in efforts and push the management wherever we are working? Because I also push the management. It is not easy. You must tell the management it is beneficial to the patient. You must tell the management this is what the research shows. You must tell the management that this is what we have tried. We know that this is effective. Please enable us to get it. One more thing I'll tell you: if you're working for a hospice or if you're working for a palliative care center, when you buy things in a bulk, right, there is always a cost. There is always a cost reduction. The cost comes down drastically. Okay, so you can even get that at a lower rate. So I would suggest push yourself to get these stuffs because these are research-wise also these are useful and beneficial to the patients. Correct. Last, let me talk about 2 more aspects and finish it off. One, the exercises are very, very important. Exercises along with the bandages are more beneficial than exercises without bandages, because exercises with the bandages help in compression, help in drainage, use the muscle pump more effectively. Last, patient education, as we already discussed. We should educate the patient and trying to get the patient back into normal life as much as possible. Functionally try to get the patient more into the normal life activities. We cannot rehabilitate, but we can definitely habilitate. What I mean to say is, in palliative care, we are trying to tell the patient to come to terms with the situation, have a realistic hope, and adapt to the available situations as much as the disease process allows. Correct? So we should be realistic. We cannot be like in general rehabilitation as we physios indulge in. We often try to bring the patient back to what they were before. We cannot do that in palliative care. There are limitations, but still we have a lot of scope to give a good functional rehabilitation to the patient and ensure a good quality of life. And that makes essence of palliative care, correct? Giving good quality of life to the patient as long as the patient is alive. Living till they die, as Bates' Saunders called it. So we can definitely do our best in this regard. And last, let me also talk about compression stockings. Do not give compression stockings, medical compression stocking, to any patient whose body part or the contour is not proper. If you are going to give medical compression stockings to any patient under your care, male or female, whose body contour is not proper, you are going to cause trouble to the patient. Redness can come, tourniquet effect can happen. So you should ensure that you do intensive phase of lymphedema management. Body contour is reasonably good, and then you take proper measurements and prescribe the right kind of medical compression stockings. This is also one word of advice that I'd like to give. So these are the aspects. And yeah, any other questions, please? Sorry, I could not show the slides properly. It's very important for us to understand the lymphatic system anatomy very clearly. before we start the treatment. And one more thing, I was very happy about the case presentation by Dr. Vandana. So the fact is that they had ruled out DVT, they had ruled out, any arterial disease before the treatment, which is very, very important, because don'ts you should be always aware of. You should always check for neurovascular compromise in any lymphedema patient. For one lymphedema patient has come, let me start the treatment. We cannot do that, or let me start the assessment. Many a times we physios fail to check the capillary filling has to be checked, radial artery pulse has to be checked. Okay, any DVT or that has to be ruled out. Okay, so arterial defects, DVT related issues, and if a person has got systemic issues like cardiac, CCF, or ESRD, end-stage renal disease, or chronic renal failure, though those things needs to be checked, hypovolemia or hyperproteinemia, we should know exactly that it is lymphedema after ruling out all the other things, right? And then start the treatment. Yeah.
Sir, we have one question regarding case. So as Dr. Vandana mentioned that there is a lump at axilla, which is visible and palpable after abduction. So, and in treatment plan, she has mentioned that ultrasound and deep tissue friction massage. So is it really indicated to use if already lump is there?
Sticking strictly to the lymphedema aspect which we are here to discuss today, I would suggest that alternate pathways must be developed for the lymph to flow. There are watershed areas. You can study about this. Watershed areas, okay, in the body. Okay, WATERSG. Watershed areas for lymphatic travel. Correct. So if there is a lump here and there is a problem with the axillary lymph node there on the right side, you can think of alternate pathways to take the lymph. Correct. You can drain it to the opposite side. You can drain it towards the inguinal side. So when you develop alternate pathways, the lymph would drain. So you need not specifically bother about the axillary lymph node which is causing trouble, actually speaking. But case-to-case basis, again, if you find symptomatic, I have not seen the patient with my eyes, correct, personally. Dr. Vandana might have observed the patient quite at a very, good proximity. She might have gone to the patient at good proximity. And she might have seen that, the lymphedema has developed, reduced to a certain extent. Maybe deep friction massage was required for some other reasons. I do not know. But then I would say, per se, ensure that once you reduce the lymphedema with proper lymphedema massage, I mean to say NLD, and develop alternate pathways for the lymph to flow. Correct? The lymph would definitely flow and develop a new pattern or new pathway to move. And once that happens, you will have a reduction in the lymph volume. Not fully at all at any point, but to a great extent. And that would sort of the matter. And you did not go for other levels of treatment.
Sir, would like to answer this question.
Yeah.
Sir, ma'am, there was not the lump, it was a cord-like structure. So actually the patient had developed axillary web syndrome. There was a axillary cording, like the patient had underwent the surgery at the axilla. There was a dissection surgery at the axillary nodes. Dissection was done. After that, the patient had developed some sort of cording. It means like there is a, like when we feel on palpation, we feel some thread-like structure at the axilla. So that actually gets pop up. Means it becomes more prominent when the patient does the overhead activity. So this is the axillary web syndrome, axillary cording also, the same thing. So for this, I have done the deep tendon, deep tissue friction massage along with the ultrasound. Even we can use laser also in this case, but I didn't prefer using the laser, so I prefer going for the ultrasound.
Thank you, madam. That's good. So see the indication why she did that. Yeah. Any other questions? So with respect to this case, do you get a better light on how to change some aspects of the management, Dr. Vandana, like with respect to the cognitive assessment and with respect to the other aspects which we talked about? Yeah, and even assessment of depression, because it's not just a distress. And there is also something called a distress thermometer, which is also easily available online. You can use the distress thermometer, which will tell you the level of distress that the individual is going through. Correct? So that we are able to understand the individual holistically. Because psychological aspect of the patient's disease is also very, very important. And if we understand the cognitive aspect of the patient, we'll be able to understand how to explain things to the patient. Because there will be limitations in understanding or interpreting what we are telling the patient. Correct? So knowing the cognitive aspect of the individual is also very, very important. Yes. Any other questions? So why do we don't use moisturizer immediately before the treatment? Why should we use the moisturizer just immediately before the treatment? Did you get the answer? Through the course of my explanation, I given the answer.
So to avoid skin irritations.
Skin irritation, you will not get proper skin traction. So you got the point. If you look at me, are you able to see my arm, forearm, and arm? You need to move the skin like this very lightly. So if you have the moisturizer or nice oil, coconut oil or anything applied, you will not get the traction. Oil will not enable give you the proper traction. So moisturizing is important, but at least there should be a gap. Application of moisturizer and you doing the treatment. Correct?
Yes.
Yeah. Because only if you have skin traction, it will drain. Yeah. Any other questions, please?
Sir, can
Hello.
you please guide about Maxell dressing? Is it really that effective?
I raised you this question. In our setup, they were using Maxell dressing for a long, long time. Many of them said that it is really, useful. But then I had discussions about, Maxell magnesium sulfate dressing, and I had discussed with many of the leading palliative doctors also in India. And I have found that this magnesium sulfate dressing per se is not the line of treatment for lymphedema. Okay, it is not the line of treatment. So kindly, if you are using it, I would say that the effects of magnesium sulfate are different. And I don't know the exact words now, but then the effects of magnesium sulfate are different. They are not useful for the treatment of lymphedema.
And if patient is having lymphedema with DVT, then what things we should exclude from the treatment protocol?
Those are all very good questions. You have a person with lymphedema and DVT. You have a person with any edema, let me tell you, any edema that you
NS also, yeah.
component, correct? Now, if DVT is present, I think you should ensure that you have a strong, good talk with the clinician, whoever is dealing with the patient. What is the extent of DVT and whether anticoagulants have been started? Only when symptomatic effects of lymphedema generally is painless. Let me repeat. Lymphedema generally will not have pain. Only the heaviness will be there because of the lymph. So pain component is there, and DVT has been, they started treating the DVT, and DVT symptoms are coming down. That's the time for you to start with lymphedema management. Correct? That is the most safest to use the lymphedema techniques on the patient. If there is cellulitis, you should ensure that the antibiotic cover is started. Correct? If there is any active wound or something, you should ensure that that wound is healed and then you start the treatment. Correct? So these are the things where you have lymphedema in combination with cellulitis and lymphedema in combination with DVT and other things. And the pneumatic compression, I have strong reservations on the use of pneumatic compression, which is used very widely. But I would suggest, recommend that you study the research evidence for that. I believe pneumatic compression devices don't do justice to the patient. Okay, only using pneumatic compression devices. Yes. Because there was a question in the chat box about that.
So Priyanshu raised her hand. Would you like to ask something, Priyanshu?
Hello, good afternoon. Yeah, I wanted to ask a question to Dr. Vandana, ma'am. So basically, this was a case of CA breast with brain mets, right? What I wanted to ask was, is ultrasound indicated to be used?
Yes, ultrasound or modalities we can give, but care should be taken. Like we should not give any modality over the active site. Like it was a case of CA breast, so we cannot give any kind of modality over the chest area, but definitely we can give it at the distal site. So in the axilla, you can give the modalities.
Ma'am, is there any supporting article with which you are following this? Because is there any evidence-based management that you're practicing? Because as far as I am aware of, we are not practicing, we do not follow ultrasound, or we do not give ultrasound. Even after the surgery has been done, the tumor has been resected.
Yes, same
We do
here.
not.
Yes, yes. Yes, you are right. Actually, we don't, studies suggest that we should not give any kind of modality over the active area, over the active site of lesion. But at the distant area, we can give, like, for example, many patients of CA breast only, they come with the brachial plexus involvement. So in that case also, we can give like the muscle stimulation, which we used to give in normal conditions in denervation. We can give this also in CA breast if the patient has developed the like the brachial plexus, or sometimes the lumbar plexopathy patient also developed in like the CA cervix, or any kind of when the patient undergoes radiation, then post radiation lumbar plexopathy also develops. So in that case also we can give the modalities, but not over the active side. And
But
studies
because-
also suggest that, like, we used to give TENS also, right?
Yes, ma'am. But the thing
We say
is,
that TENS is the safest modality
yes,
in
because
cancer patients.
TENS, as far as I am aware, it is very superficial. So TENS is usually used in cancer patients. It is highly, there is evidence, it's an evidence-based management we are following. TENS is always superficial, so it is not going to harm any of the tumor. Even in fact, on the tumor side, you can give TENS. But when it comes to ultrasound, it is highly proliferative. The cells proliferate when we use ultrasound. So as far as I am aware, and what we practice here, I'm basically from Tata Memorial Hospital, and so here we do not practice that. I do not know if there is any supporting article. I would like to know, ma'am. That's why. Thank you.
Sure. Thank you.
With respect to TENS also, I would suggest, though TENS is used very frequently, one thing that we need to be careful with TENS is we need to check the sensation of the patient. Many a times, the sensation of the patient is compromised. We always have a tendency, we give a pain, we give you TENS. But then I have personally had experiences in our setups where the sensation was compromised and we started with that. So we need more cold therapy, or even any other, even transcutaneous electrical stimulation, you should ensure that, especially with the lymphedema patient, all the more cautious, because the skin is already stretched out. You should be very cautious not to use any of this in the intensive phase. Let me tell you one more thing. Many of the symptoms that the lymphedema patients have, the heaviness and other things that they have, usually get rectified with the, after the completion of the intensive phase itself. Because once the heaviness comes down, many of the symptoms also get better. Range of motion does improve. Grip strength improves. Correct. So that is something that we have observed in our with the patient. So stick to this as a very primary, intervention on your part, and you will definitely see results.
Thank you, sir. And we have some a few questions on our chat box.
Yeah.
Question from Mr. Murugavel. Can I know, is there any difference in effectiveness with normal MLD versus concept like borders?
What is the question, please?
So can I know, is there any difference in effectiveness with normal MLD versus concept like borders? Mr. Murugavel, would you like to come up and elaborate your question?
Yeah.
Yes, sir. Go ahead.
Hello, sir. Actually, we have different types of MLD, right? Concept-based approaches, including Waters lymphatic drainage, right? They have a certain way of doing the lymph drainage. So, is there any difference, when you practice concept-based lymphatic drainage, and as usual, what we are doing is more general type of lymphatic drainage?
When it comes to, I can explain what MLD is, but I'm not aware of the other techniques of Waters. But any technique you take up, one thumb rule should be, it should have a rationale. Am I audible?
Yes.
The rationale is, now we know where the lymphatic where the accumulation of lymphatic fluid is happening, subcutaneous, correct? So any kind of aggressive measures won't be useful. We know that won't be useful. So if the technique involves gentle massage, just with skin traction, that is advisable. But anything that is aggressive, which doesn't do justice to this aspect of lymphatic anatomy, I think that is questionable. Am I able to answer your question to some extent?
Yeah, I understood. Yeah.
And one more thing, the technique. Now, how many of you are certified lymphedema therapists? Out of all the participants here, all of you are physiotherapists, I believe, right? Most of you? Yeah. Am I audible?
Yes, sir.
Yeah. So, among all of you, is there anybody who is a certified lymphedema therapist, or are you aware of courses?
So I'm a certified lymphedema therapist.
Good, madam. Thank you. So, as a certified lymphedema therapist, definitely you will have an edge in these matters, correct? So, I would definitely appreciate like more and more of us get certified in lymphedema therapy, because, madam, just for a frank understanding for all our participants, how did that help you or in getting a better understanding, getting a bigger hold on the entire lymphedema assessment and treatment?
So like before doing my certificate program, I did my certificate course from Tata Memorial Hospital, Mumbai. Before doing that, like I was, every swelling is, for me, it is just a edema. Like whether it is a swelling of DVT or it's a swelling of lymphedema, that doesn't bother me. Whenever I used to see the patients, I used to tell the few exercises along with the crepe bandaging, like we all used to do, along with elevation. This was the thing. But after doing my course, broadly, I used to, it helped me thinking to a broader aspect, like it helped me how we should differentiate between general edema or swelling from the lymphedema, what should be the concern while dealing with the patients. And previously also we used to tell the simple massage like the effleurage or the stroking massage, which we used to practice in physiotherapy to the patients. But now we never used to say, we used to say, don't do that type of massage, and I will teach you some of the self-lymphatic techniques which you can do at home also, and they are doing it, and I'm getting the result.
Thank you, madam. Thank you so much for it. We will definitely, one question has come up, would like to know the details of certification. Yes, very good question will be coming there. Now, in the beginning, somebody had told me that the management of edema involves rest, rise, compression, elevation, or positioning, price and rise and all. So now would anybody say that any kind of edema, rise and price are good in sports physiotherapy? You can go ahead with that. But then when it comes to lymphedema, please don't go with rise and price. Correct? Those things don't apply. Lymphedema, because lymphedema only in the initial stages it is amenable to elevation. Otherwise, it doesn't show any result to elevation. It is muscle pumps are the best way. Moving around reduces the edema. Most of it is lymphedema. Stemmer sign positive, lymphedema. No, these kind of things you should be doing. Anyway, certification is offered by I think Indian Lymphedema Foundation, correct? A certified professional comes from the US. Stays here for 10 days, and you have 9 hours of session every day, 45 hours of training before the session, and 90 hours daily training, hands-on, and then you write the exam for a lymphedema certification, correct? So you get a proper certification from LANA, correct? So you are a CLT LANA approved lymphedema therapist, correct? So you have to write an exam, and pass the exam, and then you get the certification. So these are the things that we should all look forward to getting certified. It's very important as physios, because palliative care is the next big thing going to happen in our country, and we should put our efforts in that direction. Yeah. Any other questions?
Sir, Priyanshu has raised her hand. Priyanshu, would you like to ask something?
Hello, sir.
Yeah.
Sir, what I wanted to ask you was basically there are common patients. What I come across is peripheral chemo-induced peripheral neuropathy and lymphedema. These are the two common cases I see in my setup. So how do we address lymphedema in such patients who has peripheral neuropathy and pain and paresthesia or allodynia? So how do we address lymphedema in those patients?
Yeah, so first you have to deal with those things first, because I told you lymphedema generally is pain-free. Generally, the heaviness is the major indicator of lymphedema. Now here you have a lot of challenges with this case. But I think you should have a proper rapport with the doctor. Many times they do start with pregabalin for some time. Correct? Pregabalin has a very good effect.
Yes, sir. Pregabalin. Pregabalin. Correct.
But then pregabalin also has its own effects in the sense it drowsiness increases. So there are indications and contraindications for that. So you need to have a good talk with the clinician and start with the medical aspect, and then start dealing with the lymphedema, I suppose, because you cannot start with anything aggressive for that per se in that individual. Given the fact that arm is swollen, you cannot use electrotherapy modalities. I think I would personally not support that. But if you have any evidence which suggests in your case or in your practice, if you come across any other better methods to deal with it, you're free to share.
No, sir, I have not. That's why I wanted to ask you if you're aware of any.
Yeah.
So, but definitely, if there is some supporting article, we'll share it definitely.
Please.
Thank you, sir.
Yeah.
So we have one more question on our chat box, and Mr. Abhilash asked, what about Faradayism under pressure regarding lymphedema?
Where is that question?
The second last question, sir. What about Faradayism under pressure?
No, is there a question that I should be answering?
Mr. Abhilash, would you like to come up and hello?
Yes, sir. I will ask. Sir, first of all, sorry to say, I cannot audible from the speaker side properly. I have an issue. I raised before itself. Then, unfortunately, I don't have any experience in this lymphedema side also. So even the academic side, no, from the college itself, we knows the lymphedema, the Faradayism and regarding the Faradayism under pressure. So my doubt is there any effect in this lymphedema? That's what I want to ask.
Faradayism under pressure, is there any effect? I need to check. Because
Yeah,
yes,
because see,
colleges have we have used that for any kind of swelling, right? Faradayism under pressure has been used for any kind of swelling, isn't it? So lymphedema per se, the entire concept of understanding lymphedema in its depth is just growing in India. Correct. So what we studied in college and what is it today needs to be checked. So I think we need more evidence to corroborate. Right.
Because I don't have any experience in this side. That's why I am asking about this, because
I appreciate that you came up with the question. Question is good, but probably I'm not the right person. So we need to think of it. Yeah.
Okay, if anyone up there, so those who are working in this area, no, they can also answer this question.
Yes.
Dr. Vandana ma'am is there. She present one case presentation here. So from the beginning itself.
Yes, you can use Faradayism under pressure, but only in case of stage 1 that will respond, and in early stage 2. But not in late stage 2 and stage 3 where fibrosis has occurred. You should actually, along with the Faradayism under pressure, you should ask the patient for volitional contraction. That means along with the movement, you should apply the this stimulation under the crepe bandaging. So there should be volitional contraction.
Okay.
And in the elevated position. But in late stage, it the patient never responds to this Faradayism under pressure.
Thank you, madam.
So you mean in the advanced state it's useless. So if you are using means we have to use at the beginning itself.
Beginning.
Am I right?
Stage 1, yeah. Stage 1 and in stage early stage 2.
At least stage 2. Oh. Because here Mr. Mathew Jinu, he explained here because the disadvantages of the crepe bandage. In the Faradayism under pressure, no, we are using the crepe bandages. Instead of the crepe bandages, instead of the crepe bandage, we can use with the stockings. We can choose the stockings or something, no?
Stockings, you have to remove it, will be very difficult. So, I don't think you should be using the stockings. The short stretch bandage instead, which I suggested, would be a good option. But for a long-term management of lymphedema, 23 hours, if you're going to put the patient on the stockings and the multi-layer dressing, I would suggest that you do this treatment, take off the bandage which you had applied and apply the entire thing. Okay, so this should be done separately, apart from the regular research-based treatment of lymphedema, that is the completely congested therapy, therapy, and multi-layer bandaging. So you should do it before that, and then put the bandage so it will be sustained to a certain extent. But again, as Madam said, Skin integrity is a matter of concern. Fibrosis should not be there. So many factors are into play. So I would say rather stick to the normal treatment as much as possible. If needed, you go with the other thing. But if you do that, do take proper precautions, because many times skin integrity will be a big problem in patients. Though at stage 1 and stage 2, it is still fine. Yeah.
Thank you, sir. Any more questions from the participant side?
So it is coming up in December. Certified lymphedema therapy training is coming up in December. We don't know the venue, but you can still search from Indian Lymphedema Foundation, ILF website, and ACOLS, ACOLS. That is also one website which intimates you about the lymphedema courses coming in. It's almost 1 lakh for one session, 15 participants only for one session, hands-on.
Thank you for that information, sir. And Kumaravil Murugan asked in our chat box, is there any reference book for that lymphedema management and its exercise and also?
Physiotherapy in palliative care and the books related to that are very few. Even the NFPM book, which I went through, the text which had articles about lymphedema did not cover the entire aspect. They only mentioned 4 pillars of lymphedema management. They missed out on the patient education part. So as of now, many books are not there, but you have enough resources in the internet where you can judge. Authentic sources are there. You can get information from LERN, LANA website, NLN, National Lymphedema Network websites. These are the websites where you get authentic standard information. Indian Lymphedema Foundation, you can go to that website where you've got Indian patients and the demonstration of CFRS, one of the videos clearly demonstrates how to treat. So you can have authentic information from these sites. Indian Lymphedema Foundation, National Lymphedema Network, LANA website, LERN website, YouTube videos from LERN. Don't go to other areas, because any information that you gather from a person who is accredited or who knows the thing well. And apart from that, BMJ offers free course on lymphedema. British Medical Journal, BMJ online, free course on lymphedema, on what is lymphedema. Please check it out. BMJ, go to BMJ websites, BMJ Learning. Enroll yourself there. You can access many free courses on metastatic spinal cord compression, on lymphedema and chronic edema, and many such courses on that website. So you can definitely go to BMJ Learning, which is a very authentic source of information on lymphedema. Management is not explained fully, but you have information, the medical aspect, the physiology.
So one book is there, like I'm having the soft copy. If everyone wants it, I can post it in the group.
What is the title?
In the WhatsApp group, best practice for the management of lymphedema.
Okay, that is authored by.
Need to see the. It's the International Consensus Best Practice for the Management of Lymphedema.
Yeah. So that's a good one. Thank you. Best practices. So that can be looked at, and go to NICE guidelines, National Institute of Clinical Excellence. Those websites which offer the latest, as the madam said, the international consensus is what is one of the contents of this book. Same way, you can go to NICE website also, which gives you the proper management of lymphedema. They're quite updated. National Institute of Clinical Excellence, right? NIC also offers, so you'll be up to date with things. That book is also a good one. I can also think of suggesting that. Yes. Any other inputs?
Yes, I think there is no other inputs from the participant side. Thank you, Mathew Jinu sir, for the wonderful and informative session. It was very informative. And special thanks to Dr. Vandana Patel for that wonderful case presentation. So I think it's time to wind up our meeting. So together it was a good informative session. So till we catch for the next section. Thank you everyone. And hand over to Mr. Vaishnav for winding up the session.